my topic of discussion is COPD. So, what is the full form of COPD? Chronic Obstructive Pulmonary Disease. So, its name itself implies its definition, right? So, it is chronic, it is not acute one. It is obstructive. That means obstruction of which thing? Obstruction of airway. The small airway obstruction is caused in COPD, right? So, there is chronic small airway obstruction. So, what is small airway? What are the small airways? What is defined as small airway? So, small airway is those airway having diameter of less than 2 millimeter. They are called as small airway. So, what are the examples of small airway? From your anatomical knowledge, they are the terminal bronchioles, they are the alveolar sac and alveoli. So, these small airways actually they involves in gaseous exchange, right? So, this COPD is the primary disease which involves the small airway, that is less than 2 millimeter diameter, right? So, this is an obstructive airway disease. What is the definition as per the gold guideline of COPD? So, what is the definition? So, this is a heterogeneous condition. This is a heterogeneous lung condition. Why this is heterogeneous? Because the manifestation of COPD differs from age to age and person to person, right? So, that's why this is heterogeneous lung condition, which is mediated by small airway obstruction and having progressive airway obstruction followed by some symptoms like airway obstruction symptoms like cough and dyspnea. So, this is the gold definition of COPD, right? Due to abnormality of the airway which causes persistent and progressive airflow obstruction, small airway obstruction. This is the definition of COPD. So, why COPD is so much important? Why? Because the prevalence of COPD is much more higher in India. Because why? Because there is increasing risk of air pollution, increasing risk of indoor pollution and smoking habit. Because of these things, there is increased incidence of and prevalence of COPD in India. Even COPD carries significant quality of life decline with significant symptom burden, leads to second most common cause of death and disability in India. That's why the knowledge of COPD is very much important for UG people, right? Because if you diagnose COPD early and treat the disease, then you may halt the progression. You may decrease the chance of mortality and exacerbation. That's why the knowledge of COPD is very much important. So, this is the current prevalence of COPD in India, right? As I have already mentioned. Next, so what are the phenotypes of COPD? As I have already mentioned in my previous slide, this is a heterogeneous condition. There are 4 to 5 phenotypes of COPD. So, what are the different phenotypes? First one is, what are the different phenotypes of COPD? First one is emphysematous phenotype, emphysema. Second one is chronic bronchitis variant. Third one is frequent exacerbator variant. That means those COPD patients having frequent exacerbations. Fourth one is asthma COPD overlap, but this asthma COPD overlap phenotype is now omitted in recent gold guideline, right? So, the main two phenotypes are emphysema and chronic bronchitis. Have you heard the term of emphysema? What is emphysema? What is emphysema? Anyone from your pathology knowledge, what is emphysema? Just a brief, yes. Emphysema is typically defined as persistent and permanent enlargement of the alveoli or distal, not alveoli, that is the distal air space to the terminal bronchiole, along with their destruction of their wall. This is called emphysema. That means enlargement of the alveoli or distal air spaces to the terminal bronchiole. So this is called emphysema. So next phenotype is chronic bronchitis phenotype. So what is bronchitis? Kono idea? Have you heard the term of bronchitis? Chronic bronchitis. This is actually, this phenotype is due to prolonged inflammatory cascade in COPD patients, results in mucus production, cough with more mucus production in consecutive 3 months, not consecutive, in 3 months in a year for 2 years, consecutive 2 years. Understood? 3 মাস 2 বছর, right? This is chronic with expectoration, cough with expectoration. This is chronic bronchitis. Chronic bronchitis predominantly happens because of goblet cell hyperplasia, because of increased mucus production. So in emphysematous variant, there is less mucus production, the cough is predominantly dry in nature, but this is not always true except in exacerbation time. And in chronic bronchitis phenotype, the cough is predominantly with expectoration, maybe mucoid or maybe mucopurulent in nature, right? So this is chronic bronchitis, and other phenotypes like the frequent exacerbator phenotypes, and as I have already mentioned, asthma, COPD, overlap syndrome. But this has been recently removed from the gold guideline. What type of inflammation COPD has? Is it neutrophilic or is it eosinophilic? What is your idea? What type of inflammation occurs in COPD? Predominantly the inflammation is neutrophilic. This is not eosinophilic. But in case of asthma, the inflammation occurs due to mediation of eosinophil. This is not neutrophilic, right? This is the basic difference between. So the basic difference between COPD and asthma is mediated by eosinophil and COPD is mediated by neutrophil. Okay, but when these two, asthma and COPD, overlaps with each other, then this symptom is called as asthma COPD overlap syndrome. Fine. Next, have you heard these terms? Blue bloaters and pink puffers. Just see the images. So blue bloaters is the patient having chronic bronchitis variant. Why this is blue and why this is pink? So blue, that means cyanosis. Blue is cyanosis. So these chronic bronchitis phenotypic patients exacerbate very frequently and they are having cyanosis, right? Central cyanosis. That's why they are called as blue bloaters, and they are actually obese and they have frequent exacerbations. Whereas the emphysematous variant, they are called as pink puffers. Why pink? As they are not having cyanosis, their skin is normal or pink. And why puffers? Puffers mean, actually this is a sign of, this is a type of respiration, part sleep breathing, you know. দেখেছিস এরকম কোন COPD patient কে? This type of breathing is called puffing or part sleep breathing. That's why this variant is called as pink puffers. They are having less chance of exacerbation, but they are cachectic. They are thin built because of chronic inflammation. They are the emphysematous variant, and they are having more chance of pneumothorax than chronic bronchitis variant. Whereas the chronic bronchitis variant may have more chance of cyanosis and exacerbation and infection as well. Because why infection? Because this variant patient have more mucus production. So mucus production increased, whereas the mucus harbors the infection, bacteria, probably gram-negative bacteria. So they are having infective exacerbations, these bronchitis variant patient. Whereas the emphysematous variant patients having air trapping, more bulla formation and more chance of pneumothorax. This is the basic difference. Next, These are the well known risk factors of COPD. The most common risk factor is smoking, right? Next most common is air pollution, maybe outdoor air pollution or maybe indoor air pollution, especially in case of female, they are exposed to indoor air pollutions, biomass fuel exposure, right? Next one, they are the post-infectory or post-infective or post-tubercular, and in case of uncontrolled asthma patients, they may turn into COPD. Regarding the genetical cause, the most common gene associated with COPD is, what is the gene? What is the genetic variant? Alpha-1 Antitrypsin Deficiency. You are familiar with the term Alpha-1 Antitrypsin Deficiency. And other risk factors are low birth weight baby, increased age more than 45 years, and male sex. They are the risk factors of COPD. So, do you have any idea about what alpha-1 antitrypsin is? What is alpha-1 antitrypsin? So, what is trypsin? What is trypsin? This is biochemistry. Any idea? No idea what is trypsin? Chymotrypsin, trypsin, no idea? Loud, bol. Interact না করলে আমি পড়াবো কি করে? বল। শুনতে পাচ্ছেন? হ্যাঁ? So actually antitrypsin, that means what antitrypsin means? What is the mechanism of antitrypsin? Yes, they are the protective proteins, protective enzymes, right? Which protects the wall from degradation, right? So alpha-1 antitrypsin is deficient. That means there is denaturation of the proteins and elastase, which is the main formulation of the cell wall of the bronchioles, right? So in alpha-1 antitrypsin deficiency patient, the elastase is debrided, right? Because of the action of the decreased action of the alpha-1 antitrypsin. So alpha-1 antitrypsin deficiency is inherited one and it is autosomal dominant, right? So what chromosome? This is your MCQ. What chromosome? This is chromosome 14 and the gene responsible is SERPINA1. So they are having 3 alleles, right? M, S and Z. So PIZZ is the phenotype or allele of the alpha-1 ATD that have the worst prognosis. So what other disease apart from the lung disease alpha-1 antitrypsin deficiency patient has? No, Wilson, not Wilson, but liver failure, hepatic failure, right? So these kind of patients have may develop COPD at early stage, less than 45 years of age, and along with that liver disease, liver failure. So then this is the pathophysiology of emphysema. So what emphysema is? Arekbar bol, what emphysema is? Just the short definition. What emphysema is? Yes, this is permanent and persistent dilatation of the airway distal to the terminal bronchiole because of the destruction of the wall. So the pathophysiology lies here. Why destruction? Because of the inflammatory cascade, right? Because of the chronic inflammatory cascade, because of the exposure of smoking and other pollutions, and because of the alpha-1 antitrypsin deficiency, what happens? This elastase is denatured, right? The cell wall is damaged. That result in permanent air space dilatation and followed by emphysema. So this is the pathophysiology of emphysema. Because of the proliferation of the extracellular matrix, because of the cell death and ineffective repair. So this is the cascade of emphysema. And what is bronchitis? What is the basic pathophysiology of bronchitis? Because of increased Mucus, what is the cause of increased mucus production? Just because of the chronic inflammation, there is hyperplasia of the goblet cell. That leads to increased mucus production. That result in chronic bronchitis. So because of the increased mucus production, what happens? The caliber of the airway is decreased. So this is the normal airway caliber and this is the thickened muscle and hypertrophied goblet cell. Because of these things, the caliber of the airway is decreased. That resulting in progressive obstruction of airway. Understood? Basic pathophysiology of COPD. So, what are the different types of emphysema? This is from your pathology knowledge. What are the different types of emphysema? Loud, jore bol, bol. Centriacinar, panacinar and no, paraseptal. So centriacinar. So what is acini? First you have to know that what is acini. What is acini? What is acini? What is acini? So acini is the primary lung unit, right? Which involves in air exchange, gaseous exchange. So acini consists of terminal bronchiole, alveolar duct, alveolar sac and alveoli. These four things are the constituents of acini, right? So the defect of COPD lies here in acini. Acini have some pores at the alveoli wall, which are called as pores of cone. Pores of cone. The primary defect, actually the pores of cone involves in collateral ventilation and gaseous exchange. So the primary defect lies in pores of cone. The defect starts from pores of cone involvement. Okay? So pores of cone and acini. So what is centriacinar? Central part of the acini is involved. What is panacinar? The whole acini is involved. And what is paraseptal? The septum, the peripheral part of the lungs are involved. Other emphysemas are scar emphysema or irregular emphysema, right? So these are the subtypes of emphysema. Centrilobular acini and paraseptal acini are caused due to smoking or outdoor pollution, right? So the centriacinar emphysema predominantly located at the upper lobe of the lung, upper part, and the panacinar are morely located in the base portion of the lung, bases of the lungs. What is the cause of panacinar emphysema? Alpha-1 ATD, right? And the paraseptal emphysema is caused due to smoking. Okay. So this is panacinar emphysema, this is centriacinar and this is normal acini. This is scar. This black things, this black thing is scar. Emphysema around the scar of the lung tissue is called scar emphysema. This is, what is this? This A, this is centriacinar, the central part of the acini is involved, and this is panacinar, this is paraseptal, right? এটা কি দেখতে পাচ্ছি সবাই? এটা কি ওখান থেকে দেখতে পাওয়া যাচ্ছে? হ্যাঁ, এই লাইট গুলো একটু বন্ধ করো তো, লাইট কে আছে এখানে? তাহলে এটা দেখা যাচ্ছে, লাইট বন্ধ করো। আর এটার একটু ব্রাইটনেসটা বাড়াও, বা এটা খুব খুব হেজি, এটা ব্রাইটনেসটা একটু বাড়াও, নাহলে দেখতেই পাচ্ছে না তো কেউ। যাই হোক, দেখ, this is centriacinar. দেখ, compare the two lung, both lung. The upper part of the right lung is more black. The upper part of the right lung is more black than the left upper lobe. So this is Centrilobular emphysema. The upper part is involved. This is pan-acinar, as the whole lung is involved more in the base, and this is paraseptal. Just look at the periphery of the lung. This is paraseptal. Paraseptal emphysema has a more chance of developing pneumothorax. So this is what is the natural history of COPD. So this famous graph is called as Fleischer-Plateau curve. Fleischer-Plateau curve. So what does it signify? If a patient, actually this is the FEV1 of non-smoker, forced expiratory volume in non-smoker patient. So they are more or less normal at the age, even at the age of 75. They are more than 60% of predicted, right? Whereas in smokers, the FEV1 declines very rapidly, especially after 45 years. So if anyone quits smoking before 45 years, then his lung function more or less may not normal, not comes to normal, but near normal. Okay? So this is called Fleischer-Plateau curve. This is the natural history of COPD. So how will you diagnose COPD? Predominantly by clinical features. Then after spirometry and radiology. So what may be the predominant clinical features? There are the symptoms of COPD. First, as I have already mentioned, cough. Cough with or without expectoration. So with expectoration, profuse expectoration, that signifies bronchitis, and without expectoration may or may not be in emphysematous variant. But just remember one thing, in all patients of COPD, when there is acute exacerbation of COPD, then the expectoration volume will be more, and it is purulent in nature. So first thing is cough. Second thing, shortness of breath. Because of the progressive destruction of the wall of alveoli and of progressive obstruction of the small airway, there will be shortness of breath, and this is also progressive in nature. At the onset of COPD, if the patient is having shortness of breath only during rest, after 2 to 5 years, the shortness of breath will increase proportionately. After 5 years, the patient may have shortness of breath even after small exertion, small exercise. So this is progressive increase of shortness of breath. But if a patient attends your OPD, which a COPD patient attends your OPD with disproportionate shortness of breath, that means the patient was not normal, the patient was having shortness of breath but not that much. But recently, during the last 1 week, the patient complains of increased shortness of breath. So the two major things you must consider. One is acute exacerbation of COPD. Second thing is development of pneumothorax. Right? So disproportionate shortness of breath, that means may have exacerbation or may have this pneumothorax. So chest pain, yes, chest pain is not common with COPD patients, but if it is associated with pneumothorax, then the patient might present with chest pain. So symptoms of heart failure, this is very important. So what heart failure you may expect from these COPD patients? In COPD patients, is it right heart or left heart? Is it right heart failure or left heart failure? This is predominantly right heart failure, what we called as cor pulmonale. Right heart failure in COPD patients is called as cor pulmonale, right? Because of the pulmonary venous congestion, pulmonary arterial hypertrophy, that leads to right heart failure. So what are the signs of COPD? First, the general look. The general look of the patient may be cachectic or may be obese. Cachectic in what phenotypical patients? Emphysema. because of the chronic inflammation, and obese in patients with chronic bronchitis. So pink puffers and blue bloaters. Next, cyanosis. Central cyanosis may be present especially in patients with acute exacerbation and this chronic bronchitis variant. So JVP, jugular venous pressure, may be engorged. So what is JVP? What is JVP? JVP signifies right heart pressure, right? Jugular venous pressure. So if the right heart is involved, that means cor pulmonale, the JVP may be engorged, right? So what are the signs of right heart failure? Engorged JVP, congestive hepatomegaly and pedal edema. These three things are the signs of heart failure, right heart failure. JVP, and next thing is clubbing. Yes, whether clubbing is present or not, in COPD, clubbing primarily is absent. But if patients of COPD having lung malignancy, this patient may have clubbing. Lung malignancy or bronchiectasis in patient of COPD may develop clubbing, right? Pedal edema in patients of COPD with cor pulmonale. Chest inspection, in chest inspection, the shape of chest will be barrel shaped. So what is barrel chest? Any idea? So what is the normal structure of chest, normal shape of chest? What is the normal shape of chest? This is elliptical in nature. So there are two diameters of chest, AP and transverse diameter, right? So in barrel chest, this AP and transverse diameter is equal, more or less 1:1. This is called barrel chest because of the emphysema. Along with that, accessory muscles. What are the accessory muscles of respiration? What are the accessory muscles of respiration? They are just from the face, alanesi, right? Orbicularis, right? Sternocleidomastoid, platysma, okay? Pectoralis major. So these muscles are the accessory muscles of respiration. So in case of COPD, especially in patients of acute exacerbation of COPD, these muscles may be prominent because of the increased respiratory rate, increased respiratory drive, okay? Second, patient may be tachypneic and pursed lip breathing, যেটা আমি প্রথমেই বললাম. What is pursed lip breathing? Okay. Next, in case of percussion, resonant note on percussion and suggesting of emphysema and hyperinflation. তোদের চেস্ট পারকাশন দেখেছিস? তোরা জানিস চেস্ট পারকাশন করতে? জানিস? প্র্যাকটিক্যাল ক্লাস আমি পড়িয়ে দেবো, যখন হবে প্র্যাকটিক্যাল আমি বলে দেবো। সো চেস্ট পারকাশন বেসিক্যালি সেকেন্ড ইন্টারকস্টাল স্পেস থেকে পারকাশ করতে করতে যেতে হয় ডাউনওয়ার্ডস, রাইট? নর্মালি from second to sixth is resonant, but in case of COPD, because of the increased lung volume, what happens? The percussion note you may heard in seventh intercostal space as well. So second from seventh ICS resonant. That means the patient may have inflammatory chest wall. There may be hyperinflation because of the emphysema. This is because of COPD. So in auscultation, decreased vesicular breath sound. In case of advanced COPD, the vesicular breath sound is too low, too decreased, and vesicular breath sound may be heard only after forceful expiration, not in normal expiration. Why? Because the small airways are severely obstructed. You may not hear the normal vesicular breath sound in normal respiration. That leads to opening up of small airway, the forceful expiration, where you may hear the this vesicular breath sound, right? And wheeze is continuous musical sound produced from the obstruction of the airway, right? But wheeze normally is not present in COPD. Why? Actually, wheeze develops from medium to large airway. This is a disease of small airway. So, wheeze is predominantly seen in asthma. But yes, wheeze, definitely wheeze, very frequently you may heard wheeze in COPD as well, in acute exacerbation, and if the disease progresses so much that it involves small and medium size airway. So, after confirming your diagnosis from your these symptoms and signs, what will be the next step of diagnosis? Yes, spirometry. From spirometry, you may diagnose the COPD, obstructive airway disease, COPD, asthma, and other obstructive airway disease. So, toder kono knowledge ache what spirometry is from your physiology class? What spirometry? Spirometry to practical chilo na spirometry? Chilo na. Okay, spirometry tale alada class nite hobe. What is spirometry? You have no idea. What is spirometry? Loud, please, loud, please. So you have to forcefully expirate, right? And after that, forceful inspiration. This is called spirometry. After forceful expiration, you measure the what will you measure? Forceful expiratory volume, FEV1, and forceful this vital capacity, and FEV6 also at 1 second and 6 seconds, FEV1 and FEV6, right? So FEV1 and FEV6, and then forceful inspiration. This makes the curve. This is the expiratory curve and this is the inspiratory curve. তোদের সত্যি স্পাইরোমেট্রি তোদের ফার্স্ট ইয়ারে হয়নি? স্পাইরোমেট্রি ফার্স্ট ইয়ারে কেউ জানিস না? স্পাইরোমেট্রি ফার্স্ট ইয়ারে তো থাকার কথা। Just you have seen the procedure, right? That's all. That's enough. Spirometry পরে পড়িয়ে দেবো in due course. So, hallmark is reduced FEV1, that is forceful expiratory volume in 1 second. Forced expiratory volume in 1 second. And what is FVC? Forced vital capacity. So actually, you have to see the ratio of FEV1 by FVC, right? FEV1 by FVC is low, less than 0.7. Mind it, the ratio must be obtained after bronchodilation. Post bronchodilatory FEV1 by FVC ratio is less than 0.7, right? This is called obstructive airway disease. After that, you should assess the FEV1, the absolute FEV1 level. If it is maybe more than 80 or less than 80, 50 to 80, 30 to 50 and less than 30. So these are the gradings of severity of COPD as per FEV1, not the FEV1 FVC. So after seeing the FEV1 by FVC ratio, you are ascertain that this is a obstructive airway disease. Fine. Next, you should assess the FEV1 absolute value, post bronchodilator FEV1 absolute value, to grade the severity of COPD. Understood? Any doubt? Fine. So this FEV1 by FVC ratio, so FEV1 is decreased significantly in obstructive airway disease, whereas FVC also may be decreased or normal. So the ratio is decreased, FEV1 by FVC decreased. But in contrast, in restrictive lung disease, FEV1, there is a forced expiratory volume, may not be reduced or may be reduced in slightly, not so much, just like obstructive airway disease. But in case of vital capacity, it is significantly reduced in case of restrictive lung disease. So the ratio, what will be the ratio? Is increased or normal because of the FVC is decreased whereas the FEV1 may be normal or slightly decreased. This is the basic difference of restrictive and obstructive lung disease from spirometry. But এটা আমি পরে একটা ক্লাস নেবো যেখানে স্পাইরোমেট্রিতে কি কি চেঞ্জ আসে দেখা যাবে, ঠিক আছে? এটা এখন ডিসকাস করতে গেলে এই পার্টটা হবে না, ঠিক আছে? সো দিস ইজ দ্য, এটার সঙ্গে এটা জানিস, দিস ইজ দ্য flow volume loop, right? And this is the volume time curve of this spirometry. Okay, so যেটা আমি এক্ষুনি বলছিলাম, there is a post bronchodilator FEV1. This is according to the Gold severity classification. Post bronchodilator FEV1 mild, that means the FEV1 is more than 80% predicted, and severe in case of FEV1 is less than 30% predicted. So in that manner you should grade the severity of the disease. Fine. So first the severity of disease by spirometry, then severity of disease assessment by your symptoms, predominantly by seeing the shortness of breath, by assessing the shortness of breath. Because cough is not the severity index, the only severity index is the shortness of breath. So shortness of breath, how will you classify severe or how will you grade the severity of shortness of breath? There is classification called as MMRC grading, Modified Medical Research Council grading. This is called MMRC grading. So MMRC grading, dyspnea grading, 0 to 4. That means 0 means no breathlessness and 4 means patient is too short of breath that he cannot leave his house or he cannot do his regular activity. He cannot dress or undress even. That much shortness of breath he is having. So this is grade 4. So keep in mind that grade the MMRC grading of severity, FEV1 grading of severity. Fine. But the most important prognostic marker of COPD is exacerbation. These things are not the prognostic markers. The most important prognostic marker is exacerbation. How frequent exacerbation of COPD in these COPD patients are occurring, these are the marker of severity. This is the marker of severity. Suppose একটা patient তোর কাছে এসছে, the patient is telling that patient is having exacerbation in last 2 months. So this is severe. This is severe despite of having FEV1, despite of having any MMRC grading. Exacerbation is the only one single prognostic factor that is important, right? So how will you grade the severity, the total severity grading? First FEV1 grading, then symptom grading, then exacerbation. So if you club together, then this Gold ABE assessment of this severity classification. So just দেখ এখানে দেখ যেটা আমি বললাম, the most important thing is this one, more than 2 moderate exacerbation or more than 1 exacerbation leading to hospitalization. This is the most important one. That means regardless of the MMRC score, the E or the severe COPD এখানে কি দেখ জাস্ট যে কোনো exacerbation থাকলে severe COPD হবে, regardless of any MMRC score, তাই তো? এইটা দেখ, চারটা দেখলেই বুঝতে পারবি, ঠিক? And what is class A? The class A is if the patient is having 0 to 1 exacerbation not leading to hospitalization and MMRC score 0 to 1 and more than 1. So this is very important ABE assessment test in your practical approach and in your so-called MCQ practice. ABE is very important, right? So এটা কোনো, this is the backbone of COPD treatment. যদি এটা বুঝতে না পারিস আবার বল, আবার আমি বোঝাবো, but this is the backbone. You must have to understand this. কোনো ডাউট এটা নিয়ে, কোনো ডাউট? This is the very important slide. কোনো ডাউট আছে? Fine. Then Radiological investigation. So, radiological investigation, X-ray or CT thorax. In X-ray, what are the diagnostic features of COPD? First, there will be hyperinflation. Fine? যেটা আমি বললাম ক্লিনিক্যাল ফিচারও তুই পারকাশন করতে করতে পারছিস, just like that. In case of X-ray, hyperinflation, that means this lung volume is increased. Lung volume is increased. Just দেখ একটা জিনিস, যখন X-ray পড়াবো তখন আমি রিপ কাউন্টিং কিভাবে করতে হয় আমি ডিটেলসে বলবো, কিভাবে ভলিউম অ্যাসেসমেন্ট করতে হয় বলবো, বাট জাস্ট একটা বলে রাখছি, দেখ, just see this lung, right lung, fine. This is the first rib, this is the first rib, so this is the second rib, this is the third rib, fourth, fifth, sixth, seventh, this is the seventh rib, fine. So the highest point of diaphragm normally cuts at the sixth rib, normally in normal patient, but when it is in seventh rib, then it is emphysema, then it is hyperinflation. First point of hyperinflation is this volume, lung volume. Second point is, just look at the diaphragm. This is the diaphragm, this is the diaphragm, but what is the normal contour of the diaphragm? C-shaped, inverse C-shaped. This is the normal contour, but is this C? This is kind of flat. So the normal diaphragm will be this one, like this, but in COPD the diaphragm will be flat. This is called flat diaphragm. Because of the hyperinflation, because of the overweight of the lungs, the diaphragm is flat. This is flat diaphragm. So how will you assess the flat diaphragm? Just after measuring diaphragmatic index. What is that? Just draw a line joining the costophrenic and cardiophrenic angle. This line, বুঝতে পারছিস, দেখতে পাচ্ছিস, this line, and distance from the highest point of diaphragm, this one. If this is less than 1.5, then you may call it as flat diaphragm. Next, look at the heart shadow. This right lung is so much hyperinflated that the cardiac shadow is compromised. So this is called tubular heart shadow. These three things are very important in diagnosing radiological finding of COPD. What are these things? First is hyperinflation, second is flat diaphragm, third is tubular heart shadow. Very, very important, right? Next, what is this? This is right upper lobe air trapping or right upper lobe bulla. This is also a sign of COPD, but this is not a mandatory sign of COPD. These three things are the mandatory signs of COPD. And this is the CT thorax. These black air spaces, just appreciate those black spaces. These are the emphysemas. These are the centriacinar emphysemas. Okay. Next, what is the treatment of stable COPD? Treatment must be classified in two terms. One is stable and one is unstable or exacerbation. So in stable COPD, this basic the first and foremost thing is, before pharmacotherapy, is cessation of smoking and avoidance of pollution exposure. Next is vaccination. As I have already mentioned in my previous class, I think the vaccination schedule of adult patients according to the Indian associations, right? So influenza yearly, pneumococcal vaccine, or this Tdap vaccine, shingles vaccine, and this COVID-19. These 5 vaccines must be taken by COPD patients to reduce the exacerbations. Second, the third thing is pulmonary rehabilitation. Pulmonary rehabilitation exercises. which increases quality of life and decreases exacerbations. Nutritional support and exercise and pharmacotherapy, not bronchodilator but pharmacotherapy. So what are the bronchodilators from your pharmacology knowledge? What are the bronchodilators? What do you mean by bronchodilator? That dilates bronchus obviously, but what are the types of bronchodilators? Any idea from your pharmacology knowledge? Beta 2 agonist and muscarinic antagonist. So these are the bronchodilators, predominant bronchodilators. So first, this muscarinic antagonist. So why muscarinic antagonist is so much important in bronchodilation? Do you have any idea what is the mechanism of this muscarinic antagonist? Long acting muscarinic antagonist or short acting muscarinic antagonist? Examples of short acting muscarinic antagonist? Pharmacology hoye geche to ager bochor hoyeche. Yes, ipratropium bromide, right? And long acting? অনেক দূরে চলে গেলি, উমেক্লিডিয়াম ঠিক আছে, but the common one, tiotropium, glycopyrronium and umeaclidine obviously, right? So actually there are three receptors of three muscarinic receptors in lung, M1, M2, M3, right? So M3 blocking, actually M1, M2 and M3, right? So M2 is autoreceptor, helps to release the ACH, acetylcholine, right? So this muscarinic antagonist, short acting muscarinic antagonist, actually they inhibit both M1, M2, M3 non-selectively. That's why they are very short and their duration is very short. But in long acting muscarinic antagonist, they predominantly block the M3 in tiotropium and glycopyrronium. Tiotropium again partially inhibit M2, but they do not inhibit the M1 one. So M3 predominantly blocked by this long acting muscarinic antagonist, which leads to bronchodilation. Actually this long acting muscarinic antagonist not only helps in symptom improvement but reduced exacerbations as well. Fine. Next is what is this? Beta 2 agonist. So what is the mechanism of beta 2 agonist? Maybe short acting or maybe long acting. Beta 2 agonist so bronchodilation to korbe, bronchodilation chhara ar ki korbe, but what is the mechanism of these things? Increased beta 2 receptor, agonism of beta 2 receptor increase CAMP production, that leads to bronchodilation. Okay, so maybe short acting or maybe long acting. Short acting one is salbutamol, levosalbutamol, albuterol, right? And this long acting salmeterol, formoterol, and there are ultra long acting as well, vilanterol. These are the ultra long acting, ultra lava, right? So beta agonist actually relieves symptom predominantly. Yes, it also reduces exacerbation, but not as much as the LAMA or the muscarinic antagonist. But the main side effect of muscarinic antagonist is anticholinergic side effect. That means dryness of mouth, right? Glaucoma, increased risk of glaucoma. So in case of COPD patients, in case of those patients, actually those COPD patients who are having exacerbation and you are prescribing LAMA or muscarinic antagonist in nebulization, keep in mind that it may harm your eye also, increased chance of glaucoma. So yes, the most effective treatment is combination of LABA plus LAMA, right? And other one is inhaled corticosteroid. So actually this is the mainstay of treatment. Is this the mainstay of treatment of COPD? No, this is not the mainstay. Inhaled corticosteroid is not the mainstay of treatment of COPD. Actually we have to, actually we try to avoid ICS prescribing. Why? Because this is not eosinophilic, this is predominantly neutrophilic one. ICS decreases eosinophilic inflammation, especially in case of asthma, So in asthma, the primary therapy is ICS, inhaled corticosteroid, but in COPD, this is not the primary treatment. Only if the patient is having frequent exacerbation or patient is not having pneumonia or tuberculosis, because ICS weakens immune system, which may flare up the TB or pneumonia infections. So before prescribing inhaled corticosteroid, you must have to ascertain the patient is not in acute infection, the patient is having frequent exacerbation, and the most important thing is the peripheral eosinophil count must be more than 300. This is the criteria of prescribing inhaled corticosteroid. So next, oral glucocorticosteroid. This is not routinely used, only used in exacerbation, only acute exacerbations. Theophylline. So what is theophylline? What is the class of theophylline? This is methyl xanthine. So methyl xanthine, what is the mechanism of methyl xanthine? ভুলে গেছিস কি করে বল ওই একই সেম CAMP ইনক্রিজ করে bronchodilation করে but actually theophylline is not the mainstay of treatment of COPD because it causes bronchodilation only 10%. মানে actually the first line treatment is LABA or LAMA. After that the patient is frequently exacerbating or not, the symptom is not relieved, then only you can prescribe theophylline, the add-on treatment. This is not a primary treatment of A. So theophylline they are having very narrow therapeutic index. That's why it is not preferred to use theophylline as a mainstay of treatment. PDE4 inhibitor, this is the newer one, roflumilast. This is a selective PDE4 inhibitor. Roflumilast, and the last thing is one antibiotic is very important. One antibiotic is very important in reducing exacerbation of COPD. What is that? Macrolide, azithromycin. Macrolide, long-term macrolide for more than 3 months. For 3 months, that is thrice weekly dose. In thrice weekly dose may reduce exacerbation, azithromycin. So this is the treatment protocol, treatment chart. আমি এই জন্য বলেছিলাম ABE assessment chart টা রিমাইন্ড করা is very important এই যে because of these things. In case of A, what is A? আমাকে বল একটু রিমাইন্ড করো তো. What is A? What is A? Class A, gold A. Exacerbation 0 to 1 and MMRC 0 to 1 or CAT score less than 10. That means exacerbation হয়নি or কম and the symptom is very less. This is group A. What is the drug of choice in group A? Any bronchodilator, maybe SABA, that is short acting, maybe LABA, maybe LAMA, any bronchodilator. Second is group B. So what is group B? Exacerbation is 0 to 1 but the symptom is more. MMRC score is more than 1 or CAT score is more than 10. CAT means COPD assessment tool. CAT, full form of CAT. So CAT score is more than 10 or MMRC is more than 1. So this is group B. Group B, in group B patients, LABA or LAMA or anyone, LABA or LAMA, do not combine LABA. And in what is group E? Frequent exacerbators, more than 2 or more than 1 leading to hospitalization, regardless of the symptoms. In this strata of patient, the drug of choice is combination therapy, LABA plus LAMA. Fine. And you may add corticosteroid, inhaled corticosteroid in আমি যেগুলো আগে বললাম, in those patients, eosinophil level more than 300 and frequent exacerbation, not having pneumonia or tuberculosis. Escalation of therapy. So if a patient is on LABA, further he deteriorates, he is dysphoric, then you may add LAMA to it, or vice versa. They are on LAMA, you may add LABA if the dyspnea persists. And frequent exacerbation, ICS, triple combination, LABA, LAMA, ICS. But যেটা বলা হয় to increase the adherence, always combine these things in one inhaler, one single inhaler. LABA, LAMA, ICS, maybe LABA plus LAMA, one single inhaler, not two inhalers, right? What is the treatment of exacerbation? So what is exacerbation? What is exacerbation? In COPD patients, exacerbation defined as increased shortness of breath, increased cough with purulent expectoration in COPD diagnosed patient. This is called exacerbations. So in exacerbation may be mild, moderate or severe. So in case of mild exacerbation, you may treat the patient in your home also or OPD basis. In severe exacerbation, you must admit the patient in ICU or ward as per the severity. Okay. So in severe exacerbation, nebulize with bronchodilators, give steroids, right, and antibiotics if the patient is having purulent expectoration or having fever. Yes, the most important thing is the most important organism or type of organism actually which may lead to exacerbation of COPD are viruses and bacteria, right? So viruses, that means adenovirus, and most important is influenza adenovirus, and bacteria, the most important is which bacteria? Most important 3 bacteria. Name 3 bacteria that causes COPD exacerbation. Moraxella catarrhalis, Haemophilus influenza and Streptococcus pneumoniae. These 3 organisms are the most important one.